Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and I'm pediatrician by profession, teacher by passion. We are discussing this amazing series of NEET SS previous year's topics. For today's discussion, we have important topic of stomach anomalies in newborn or children. So this is very important. Without further delay, we'll start. The star topic today is congenital hypertrophic pyloric stenosis. Okay, so hypertrophic pyloric stenosis is the important condition, HPS is also called. This is seen in mostly white infants and this is less frequent in black or Asian population. So this is more common in West population than Indian population. Okay, male are affected 4 times more than females. So male female ratio is 4:1 and particularly first born male. So this is important. Okay, so in this slide we have seen white infant, male and female ratio is 4:1 and firstborn male is involved. One statement is there, approximately 20% of male and 10% of female offspring with a mother with pyloric stenosis will develop this condition. Okay, if mother has history of pyloric stenosis, 20% of her male child and 10% of her female child will develop this congenital hypertrophic pyloric stenosis. So, what are the associated conditions with this? If you found this patient, what can be other conditions? Just think of. So, tracheoesophageal fistula, hypoplasia or agenesis of inferior labial frenulum. This is important and one case report of this condition also exists, which supports that this condition is associated with inferior labial frenulum, agenesis or aplasia. Once we try to find out the causes of this congenital hypertrophic pyloric stenosis, exact cause is remain unclear. There is no cause, but there are some genetic factors are still under investigations. Some syndromes are associated, like esophageal gastroenteritis, Apert syndrome, trisomy 18. Zellweger syndrome, Smith-Lemli-Opitz syndrome, and Cornelia-de Lange syndrome. You don't have to remember all these syndromes, but just remember some syndromic association is also there for this syndrome. The important thing of erythromycin, if a newborn or mother happen to take erythromycin first 2 weeks of life, then there are chances of having this condition, congenital hypertrophic pyloric stenosis is there. What are the other risk factors which can be modifiable, like formula feeding, maternal smoking is very bad, so this is also one of the causative factor of this, and abnormal muscle innervation, hypergastrinemia, elevated serum prostaglandin. Are any genetic loci for this syndrome? Yes, multiple 12q, 16p, 11q. So don't have to remember. Don't these conditions don't have any pinpoint genetic foci. Nitric oxide synthetase gene NOSI is also involved. So genetic point of view, this one have to remember this also. Okay, what we essentially are talking about, this is stomach and this is actually obstruction at this level, stomach level. Okay, stomach outlet level. So one is idiopathic hypertrophic pyloric stenosis. Now it is called idiopathic because we don't know it is congenital or it is not congenital. So this is other conditions are like congenital, which is aplasia, atresia, web, or gastric duplication. What are the acquired condition which can this gastric outlet obstruction like peptic ulcer disease, like gastric chemical injuries associated with Crohn disease, chronic granulomatous disease, eosinophilic gastroenteritis, tumor and gastric volvulus. So congenital, acquired, and in between our condition, which is now termed at is idiopathic congenital hypertrophic pyloric stenosis. What are the clinical manifestations? So, non-bilious vomiting, because this is above, this obstruction is above from second part of duodenum. So, non-bilious vomiting, which is projectile, and the age presentation is between 3 weeks to 5 months of age. Some rare cases of late onset between 2 to 8 years, and hunger after vomiting. So this is important. Non-bilious vomiting is the one thing. Projectile vomiting, and typically between 3 weeks to 5 months of age, with rare cases of late onset between 2 to 8 years of age. And hunger after vomiting is there. So this is typical classical presentation of idiopathic or congenital hypertrophic pyloric stenosis. Metabolic alkalosis. So once child is vomiting, then loss of fluid, loss of chloride, and loss of hydrogen ion leads to hypochloremic metabolic acidosis. Again, this entity is very important. Hypochloremic metabolic acidosis. Hyperbilirubinemia, most common association, icteropyloric syndrome. So icteropyloric syndrome is the most common association of this idiopathic congenital hypertrophic pyloric stenosis. Unconjugated hyperbilirubinemia is there, and there is possible association of Gilbert syndrome due to mutation in UGT1A gene. So this is also important. Severe dehydration is also there due to repeated vomitings leading to fluid and electrolyte imbalance. How you will diagnose this patient, or how these patients will clinically present and you will diagnose? You have to palpate this pyloric mass. So this is olive shape, as we can see. This is firm. This is movable mass, approximately 2 centimeter in length. Best palpate when palpated when infant is lying on left side and located above and to the right of umbilicus. These mass description of this CHPS is important. So just remember, this is olive shape, this is firm, this is movable, 2 centimeter in length. When infant is lying on left side, it is more prominent and located above and right of umbilicus. So this is important. So how you will do the diagnosis? USG is the important. Pyloric, remember 414 rule, I'll tell it later. But just remember, pyloric thickness more than 4 millimeter, pyloric length is more than 14 millimeter, and pyloric diameter is 10 to 14 millimeter. Upper GI contrast studies, we have theoretical question, string sign, shoulder sign seen. So just remember, the thickness is more than 4 millimeter, and pyloric length is more than 14 millimeter. This is pyloric. Okay, so this is important. This is actually thickness and this is length. So these two figures are important. Thickness more than 4 millimeter and pyloric length is more than 14 millimeter is almost diagnostic of this condition. You can see here barium in barium enema, actually barium of stomach, barium meal. So you can see just the tapering of barium. Double tract sign also seen. So what are the differential diagnosis? Just see if it is you are not missing out GRD. Adrenogenital syndrome, very important. This one of the DD of this condition is adrenogenital syndrome. So this can mimic pyloric stenosis but with metabolic acidosis and electrolyte imbalances. So in adrenogenital syndrome, metabolic acidosis and electrolyte imbalance is present. Inborn error of metabolism can present like vomiting. Infections can be there, pyloric membrane and duodenal stenosis can be there. So how you will treatment? First, you will stabilize the patient with the rehydration, anti-suction, antacid. So this is the management of just pre-operative management or stabilization of patient. What will you will do? Stomach is like stenosis, outer stenosed. So You will do pyloromyotomy. Just you will cut this muscle. So this is actually treatment of choice. What we see, a RAM stated procedure. This is open pyloromyotomy. This is traditional. So this is traditional RAM stated procedure, traditional open pyloromyotomy. But obviously in this era, we can do laparoscopic pyloromyotomy also. So this is important. And now this is treatment of choice. Success rate is high. So post-operative care, you can resume feeding after 12 to 24 hours. Post-operative vomiting mostly seen in 50% infant, generally due to edema at incision site. So persistent vomiting, endoscopic balloon dilation you can do, or complication GRD can occur. Okay, so outcome is good, nothing to worry about. Other anomalies of stomach, we just will discuss briefly of other anomalies of stomach from this table. Like you can see gastric or pyloric atresia, non-glaze vomiting, pyloric or antral membrane, microgastria, gastric diverticulum, gastric duplication, gastric teratoma, gastric volvulus, pyloric stenosis, congenital absence of pylorus. So just remember these things. Presentation will be like of these things, and diagnosis will be sonography or sonography or studies. Okay, so this was it for stomach anomalies. Mainly we discussed congenital hypertrophic pyloric stenosis, which is now called as idiopathic hypertrophic pyloric stenosis. So just see this condition, and we will meet in another video for discussion in this amazing series. Till then, stay tuned.